Pancreatic cancer is a lethal disease. As per Globocan India data, it is 24th most common malignancy, detected malignancy, despite of the so much advances in the in our field, we still don't have the definitive answers for treating it. Surgical resection remains the only curative options. More than 80% of the resectable patients presents with the unresectable disease. So it is very prudent to identify and classify the patients based upon the resectability. As we all know, the primary objective of the surgery is to achieve margin negative, that is R0 resection. Pancreatic ductal adenocarcinoma is deemed resectable if only if negative resection margins can be achieved. But to R28, the assessment of the resectability is based on the preoperative imaging. These are the various definition of the resectability criteria which we use in pancreatic cancers. On my left there is AHPBA definition, and on my left AHPBA definitions, and on my right side of the screen is NCCN definition of the resectable, where there is no contact with the portal vein or superior mesenteric vein, or less than 180-degree contact with vein contour irregularity, and there is no contact with the arterial vessel. But is this the anatomical criteria enough to define the resectability? I guess the answer lies that in this paper, which was a national cancer, which was data from the national cancer database studies, which included that almost uh, non-secretors. Sorry, sir. Non-secretors had a survival similar to that of the survival with the patients with the same similar as the normal levels. This was the one which was unadjusted overall. This pictorial representation which demonstrate the unadjusted overall survival of the stage 1 pancreatic cancer, which was stratified by CA99 level. All the surgical patients who has elevated CA99 level more than normal, that is 37, they had comparatively they fared bad when compared to those patients with CA99. Those fall in the normal range. But even if you see in the surgery alone group, or the surgery followed by adjuvant chemotherapy group, they fared bad when compared to the patients with the CA99 level. But only the new in those patients who had preoperatively raised CA99 level, and those who were administered neoadjuvant chemotherapy, this was the only group which was shown that the administration of this neoadjuvant chemotherapy had negated the effect of elevated CA99. What are there are historical and the future treatment trends overview. It's a many factor contribute to the outcome of the pancreatic cancer. It's a tumor biology, patient factor, and the treatment factor. uh, we have witnessed the dynamism in the treatment of the pancreatic cancer with our sole aim to improve the outcome in the terms of overall survival, disease free survival, distance met free survival, or local regional control with the use of multimodality treatment. These are the various advances we have incorporated in our practice in order to improve the overall outcomes of the pancreatic cancer. These are the various previous trial, but why neoadjuvant chemotherapy has a role in a resectable pancreatic head cancer? That is a question pop up in mind, because the significant number of the patient does not recover fully within 3 months following surgical resection to receive the full course of adjuvant therapy. That is one of the most important factor when those patients who underwent pancreatic surgeries, they are either they are fail, or they are marred with the complications that will prevent them for take going with the further therapy of adjuvant chemotherapy. Aggressive nature of the pancreatic cancer and its ability to metastasize early in the course of the disease which has been demonstrated by various trials, that it is a systemic disease right from the onset, be it resectable, be it borderline resectable pancreatic cancer. So, as a with the incorporation of neoadjuvant therapy, we can treat the earlier, we can treat the micrometastatic disease, which would be more likely to responsible for the high failure rate following the surgical resection. And administration of the neoadjuvant therapy before the physiological stress of the surgery, it may allow the patients to receive the full course of cytotoxic chemotherapy. Majority of the trials have demonstrated that the following the surgery, surgery for the pancreatic cancer, majority of the patient does not receive the full course of chemotherapy, allowing for the better selection of the patients, as more aggressive diseases will declare itself by progressing during the chemotherapy, and this will spare the patient with the morbidity of the surgical operation. This was a paper which was published in JAMA, which defined the association of the timing of adjuvant therapy with the survival in the patient with resected stage 1 and stage 2 pancreatic cancer, which was in this, there were three groups. They divided it in the three groups. Early groups, which was administration of the chemotherapy within 28 days, and late group was beyond 60 days, and 28 to 59 days was the reference group. And this demonstrated this study demonstrated that patient with the stage 1 and stage 2 pancreatic cancer who commenced adjuvant therapy within 28 to 59 days after primary surgical resection has improved survival when compared to the early group as well as the late group. As we can see, the 2-year overall survival was 52.5% when compared with the early group, and it was similar 51.3% when compared with the late group. So the timing of administration of chemotherapy is also important, because majority of the patient will not recover fully to receive the full dose of chemotherapy following surgical resection. So making a point that before subjecting a patient to a surgery, when neoadjuvant chemotherapy, a full dose of chemotherapy can be given prior to surgery. Post-operative complications. We all know pancreatic surgeries comes with it comes with its own set of complications, and how the post-operative complications will reduce the administration of adjuvant chemotherapy. This was a paper published by Merco et al. In Annals of Surgery. They had found that the serious complications increase the likelihood of not receiving the adjuvant chemotherapy by 2-4 ratios, and it also double the likelihood of delaying adjuvant treatment by almost twice. So in this, they have defined the delay of the chemotherapy as more than 70 days after the index procedure. They had found that the five complications, like serious complications, organ or deep space surgical site infections, wound adhesions, pneumonia, septic shock, they are the one which are the 5 factors which resulted in delaying of the adjuvant therapy or omission of the adjuvant therapy. Post-operative complications deteriorate long-term outcomes in the pancreatic cancer patients. This study found that when the patient suffered grade 3 or grade 4 complications, they had median survival of only 15.5 months. When they had complication of oral grade 1 to grade 4 of 32.7%, but the occurrence of the severe postoperative complication was associated with significantly shortened survival interval of 16.5 versus 12.4 months, which was statistically significant, and it was identified as independent prognostic factors. And in this study, they also found that the R0 resection rate as well as severe complications and lymph node status all were prognostic factor for the outcomes, prognostic indicators that may impart the outcome results. This is a secondary analysis. This was a paper on the secondary analysis of ASPAC-4 randomized adjuvant chemotherapy trial. Despite the standard of the care that adjuvant following surgery administration of the adjuvant therapy, disease recurred in this study. They found that disease recurred in around 65% of the patients, of which 50 had local recurrence and 40% has distance recurrence. The median overall survival time to recurrence was around 12 months, and of these 458 patients who recurrence, they recurrence was one of the reason for that. Recurrence was the cause of the death in these patients. So, imparting this is also one trial that despite the standard of the care administration of the adjuvant chemotherapy, the patient will eventually around 65% the disease will recur. So, it also makes us to think: are we? Is it the right strategy of treating the pancreatic head resectable cancer? Multiple trials have been conducted to assess the neoadjuvant chemotherapy for resectable disease. Most earlier trials were small studies and used the regimens such as gemcitabine and 5-fluorouracil with or without radiation. Henrik et al. Studied the effect of neoadjuvant chemotherapy in a small set of the patients, gemcitabine and cisplatin in 28 patients. The takeaway point of this study was 93% underwent resection and they had median overall survival of 26.5 months. These are the various studies which have been undertaken to demonstrate in resectable pancreatic cancer, which neoadjuvant chemotherapy alone, neoadjuvant chemoradiation, and perioperative therapy with administration of radiation post-operatively. These are the earlier phase 2. Majority of them are retrospective or phase 2 trials. But the one of the most spoken trial was by Sato et al. From the Japan. It was a multicentric prospective study comparing the neoadjuvant chemotherapy using gemcitabine and S1 with upfront surgery. It showed that significant survival benefits from the neoadjuvant therapy. This was a phase 3 trial, and it shows that median OS was 36.7 months when compared to 26.6 months in the upfront surgical group, which was statistically significant. Significant decrease of viable tumor cells was observed in primary tumor after neoadjuvant chemotherapy when compared with the upfront surgical group. Even the pathological regression score, evens 2B or more, was found in only 14% of the resected cancer in neoadjuvant chemotherapy group. This was a phase 3 PRIOPANC trial, which was conducted by Dutch Pancreatic Cancer Group. This was a trial which included chemoradiation, which compared the chemoradiation with surgery followed by adjuvant therapy. This was this trial had a primary primary aim or primary endpoint was overall survival, and secondary endpoint has where R0 resection rate, distance-free survival, distance metastasis-free interval, and locoregional interval and perioperative complications. This was the trial designs in which the patients were randomized. This trial, though it failed to show the primary objective, that is median survival, median overall survival, which was in the preoperative group, it was 16 months, whereas in immediate surgical group, it was 14.3 months. But the takeaway point of this study was the secondary endpoints that were median disease-free survival as well as median loco-regional free survival, which was statistically significant, and the R0 resection rate that could be achieved with preoperative therapy group, which was 70%, around 70% in the preoperative group, when compared to the immediate surgical group, it was just 40%, which was statistically significant. The consistent benefit for most secondary endpoints and better compliance with the perioperative chemoradiotherapy compared with the post-operative adjuvant therapy suggests the superiority of the neoadjuvant approach. But the limitations of this study was it used only single agent chemotherapy, whereas multi agent now the data supporting multi agent chemotherapy is effective. There were other confounding factors. 14 patient had diagnosis other than pancreatic ductal adenocarcinoma, and despite there was a delay in administration of the therapy in pre-op group due to persistent raised bilirubin despite a drainage. And there was one more confounding factor was the factor was addition of the new radiation in the preoperative. Was it negate the effect of the chemotherapy? That was not answered. This is a on my left of the screen. It shows overall survival in patients. It has no statistically significant, but when we see on the those patients who completed the whole course of the chemotherapy, that is post surgical NACT followed by surgical resection and administration of uh, uh, adjuvant chemotherapy following it, they showed that they had overall survival better than immediate surgery, as well as also in the disease-free survival, locoregional free survival interval, and distance metastasis-free survival, which was statistically significant if the patient had finished the whole course of chemotherapy, that is neoadjuvant chemotherapy followed by surgical resection as well as adjuvant chemotherapy. This was a one more trial, SWOG S1501, which compared the results of perioperative chemotherapy with M-FOLFIRINOX versus gemcitabine and nab-paclitaxel for resectable pancreatic ductal adenocarcinoma. So with the previous trial having demonstrated that there is a role of neoadjuvant chemotherapy, then there was a further there was a further development which regimen is ideal for a neoadjuvant chemotherapy. Is it the M-FOLFIRINOX or gemcitabine with nab-paclitaxel? Which regimen is better? It's not a part of this debate, but it is the how that has improved the outcome in the patients. This was this study design was pick the winner design, which where the patient were randomized, were expected to show 58% survival advantage at the end of 2 years interval. That was the primary aim of this study, but unfortunately this study did not fulfill its primary objective, that is at the 2 year none of these regimen had shown the 58% of the survival advantage. But the surgical this was a paper which demonstrated the surgical outcome results from the SWOG S1501 study. Out of the 102 eligible patients, even in spite of administration of M-FOLFIRINOX or gem-nab-paclitaxel as a neoadjuvant chemotherapy regimen, only 75% of these patients who were eligible could reach up to the reach for the surgical surgery, and 25% of the patient did not underwent the as they were planned, because they were, as reason documented, patient refusal. Progression of the disease was observed in 36% of the patients, proves that though it is a resectable pancreatic malignancy, it is a from the early onset of the disease, it is the systemic disease. Symptomatic deterioration, and 36% of the study population could not bear the toxicity, and they were not they did not underwent the surgery. And of those who underwent resection, uh, they reached surgery. There was one patient did not undergo surgery because of complication, and only the 73% of the patients were of the eligible patients underwent resections. And this is the benefit of this study. It demonstrated that almost 85% of the patient, irrespective of what regimen, either it is M-FOLFIRINOX or gem-nab-paclitaxel, 85% of the patients could receive R0 resection, which is which is a good result for the pancreatic malignancies. And the total number of the nodes that were resected were 18 on median. And the pathological response, the one of the takeaway point of this study was the pathological response that was almost 33% in, as per American Association of Pathologists, it grade 0, grade 1 was observed in 33% of the patient. Considering all these factors, it is a early systemic disease right from the onset of the disease, and majority of the patients who underwent surgical resection upfront surgeries, they have complications which will prevent them from undergoing further definitive further adjuvant chemotherapy. And uh, the outcome, the timing of the adjuvant chemotherapy, because of the complications, the patients will be the administration of the chemotherapy will be delayed. All these factors, because of all these factors, administration of new chemotherapy in the preoperative setting, that is neoadjuvant chemotherapy, is a very valid strategy, because it will help to identify patients who are more aggressive, because those will progress even on the chemotherapy, and in such patients the surgical morbidity can be avoided, and surgical morbidity can be avoided. Based upon this, uh, I rest my debate with in favor of administration of neoadjuvant chemotherapy in resectable pancreatic head malignancies.
Good, Shailesh, how would you want to take it? You complete the second debate and then you say the pros and cons of each evidence, and then you will give the expert talk and comments. Shailesh? Shailesh?
Hear me?
Yeah, yeah.
Yeah,
Do you want
sorry. So,
this
so I
section
think
on?
there are two ways of looking at it. One is
Yeah,
that Yogesh has made an excellent presentation, and we have heard all the detailed studies that he has cited. I've
yes.
studied each and every one of these slides, and he's made a good case for looking at neoadjuvant treatment as an option in resectable pancreas cancer. Um, at the end, he has, of course, said that the answer and the way forward is only neoadjuvant treatment, which is good. So I think it's important that we hear the counter from Dr. Gayatri, and then, of course, we can have a lengthy discussion and a talk, if that is okay with you, Soma.
Absolutely, absolutely. And also, let me formally welcome Shailesh. He doesn't need introduction. He's a world authority on pancreas, in the world. And he's extremely busy because he launched two caps, not only as a fantastic surgeon clinician, as a great administrator in Tata. And in Tata, if you need to be administrator, it is real full time. I don't know how he manages, and he manages very efficiently. Such a busy person, world authority, who is called for all the oration globally. He humbly accepted to teach our own students. Shailesh, my heartfelt thanks. That shows a great heart and the mind and teaching you have. And I'm thoroughly enjoying, because you are authority. If somebody can write a commentary to Lancet on this debate, it is you. Thank you very much for accepting. And students, please utilize this opportunity. All the questions in the chat box or Q&A at the end of it will be answered by him, pros and cons, and he will answer. Thank you very much, Shailesh, and welcome formally.
Thank you so much, Soma. It's a real pleasure and privilege. And being in Tata, I think it's very standard that service, research, and education. And in terms of service and education, I don't think I have stopped in the last 20 years at all. So thank you for your flattering words. I'm sure everyone doesn't believe that, and that's good. But I'm very happy to be here and see you here on a Saturday morning with your customary enthusiasm. And now let's look forward to the next talk by Dr. Gayatri. And then, of course, we will have a long discussion.
Gayatri, over to you.
Yes, sir. Good morning, everybody. Wishing you a very happy Diwali and a new year. It's great that we are starting the new year with such great academic help from Dr. Shailesh Shikhande sir, and always backed by Dr. Somsekhar sir. Sir, today my topic is in operable pancreatic pancreatic cancer, head of pancreas, we should go for upfront surgery or not, and I will support the evidence accordingly. Dr. Yogesh has kind of made my work easier because my first 20 slides were on defining the disease and giving the data about it, but I will skip that part, sir. So I just want to make another point. There was a new concept. I'll just start my slideshow, sir.
Gayatri, you don't have to skip because we have time. Go ahead. Repetition for student always good. And point can be looked into perspective. I would love to see the same slides, how you interpret it. Please go ahead.
Yes. Okay, sir.
Important
So,
point, Soma, that you can see the same slide differently. That's very true. Very well said.
yes, so it's not exactly the same, some difference, but the content is almost similar. Okay, sir. From the beginning, we know that CA pancreas is a lethal disease. It's sixth with the death ratio that we have. We know that how much ever we try, that the overall 2 year survival was very low, as said by Dr. Yogesh. But we, in the recent past, we also have very good data sharing that the overall survival has increased. And now with the recent data of standard treatment, that is surgery with adjuvant, the PRODIGE 24 also has said that the median overall survival has gone up to 54 months. Just reviewing CA pancreas as a disease, we know that what we get in the OPD would be obstructive jaundice, that is 75%, and 40% of the patients come with pain, fatigue, pruritus. Weight loss is in 50%, and new onset diabetes and depression, and pale stools are the other symptoms which we get. We know that we evaluate the disease with normal, with basic blood investigations, concentrating more on the liver function test with coagulation profile, CA, and the most important serum marker, which is CA99 as a tumor marker. We also know that to image and to classify the disease, which is into resectable, borderline resectable, and locally advanced, we use the pancreas protocol CT. And there is a role in certain situations of ERCP and biliary stenting if the total bilirubin as cutoff, as said by literature, is more than 15. And we do use CT, thorax, abdomen, pelvis to exclude metastasis in asymptomatic patients. And also if there are symptoms, there is a role of PET, which is not yet come into the NCCN guidelines. And here is the definition by the latest NCCN, as defined earlier, as resectable head pancreas is that disease which does not contact the celiac axis and the superior mesenteric artery or the common hepatic artery, and no contact to the superior mesenteric vein or less than portal vein or less than 180 contact, which we can reconstruct portal venous resection and reconstruction, as will be defined in some time. This is also called potentially resectable disease, and has been tried, and I have also witnessed 1 or 2 cases of it, and the patients do have an R0 resection after that. We already know that borderline and locally advanced, there is a standard of care established of neoadjuvant chemotherapy and radiation along with SBRT, and then plan for surgery. So the topic of the debate would be the resectable pancreatic cancer today. In the definition of resectability, we see that it should be operable. The patient should be medical fit for a Whipple's at a pancreatic or duodenectomy. We should not have any evidence of metastasis, and imaging should show that the patients have resectable disease. As I said earlier, the concept of potentially resectable is the one which has portal venous involvement, but it is to an extent that can be resected, and an end-to-end anastomosis or a graft anastomosis can be done. These are only done in situations where the surgeon has a very good experience and it's a high volume center, and also they are confident that then R0 resection will be possible. These are some gray areas where we know that CA 99 is only limited for monitoring and not screening the disease, and we should screen CA pancreas in patients with two first degree relatives and known of cases with Pers-Jaegers and BRCA2 and Lynch mutation. And these patients are also started with an US and MRI at 50 years and then followed annually, which was recommended by the CAPS Consortium 2013. The role of biopsy is not defined. It is defined, but biopsy is not necessary in all cases. Whenever there is a mass on imaging and there is a high suspicion of CA pancreas, we can go ahead and operate. The role of biopsy comes when an alternate diagnosis is likely or NACT has to be given. When we say when we see on imaging that's a borderline resectable and a locally advanced case, or we are suspecting a lymphoma. We know that the prognostic predictors of the disease are CA 19 level, as said by Dr. Yogesh, as a cutoff of 37. If the lymph node status is also important, if it is N2, that is more than 3 lymph nodes positive, has a poor prognostication. If it is a poorly differentiated adenocarcinoma and a bulky tumor which is 3 centimeter mass, these are still weak markers as per the data. This is the NCCN guideline of what I have just described. Germline mutation is done in all in all pancreatic cancers. I'm sure I don't need to go through the staging. So approach in resectable pancreatic cancer, there are two pathways. One is we proceed with surgery without NACT, and the other is we undergo a US guided biopsy when we consider NACT and stent. That is, if the bilirubin is above 15 or the patient has symptoms and is not having a good performance status for surgery, can consider NACT and then restage the disease, and then go for a diagnostic laparoscopy, and then if we feel it is resectable, go ahead for an R0 surgical resection. This is the standard protocol when prior neoadjuvant therapy is not given. We go for chemotherapy. I will describe the adjuvant trials here ahead. And then after adjuvant chemotherapy is given, the patient undergoes surveillance 3 to 6 monthly for 2 years, and then every 6 monthly. With 3 parts, that is clinical, biological, and imaging. That is, you see how the patient is doing, how is his ECOG status, how is the weight gain, any symptoms of pain, showing recurrence of disease, or then see at the CA 99 level whether it is in an ascending trend, that is the biological markers, and the imaging, which is the CT scan or the MRI of the abdomen. So let's get on to the main topic, main debate. This is our aim of any disease would be to increase survival, decrease morbidity of treatment, and maintain the quality of life. To this, I would add another thing. Being in India and with limited resources, we need to objectively think of how we can reduce the overall expenditure of the patient so that the resources are allocated to more people in need. So we have to also see the increased survival, decreased morbidity, how the patient is maintaining his quality, and also what fits into the best to the situation. Hence, despite the surgical advances, why has this debate come up? Is because the survival rates are remaining poor even after surgery and adjuvant treatment. Hence, we are trying to improve the overall survival in resectable pancreatic cancer. Also, there has been overall adoption of NACT and NACRT in borderline resectable and locally advanced, and hence the proponents of NACT are trying to get into the idea into whether we should directly operate or not. And also, some papers say that extrapolating the findings from NACRT from the other organs which achieve a very good PCR, that is pathological complete response, is it applicable to pancreas as well? So as Dr. Yogesh has said, I would also add some points which I noted during his presentation, that he said that the recurrence rate is high, NACT is tolerated better than adjuvant, and approximately 15 to 30% may not receive adjuvant chemotherapy. And with NACT, we are getting an idea of tumor biology and sensitivity to drugs, which can be changed in the adjuvant setting. But also, he said that the rate of the R0 resection in the Preopang trial was better with NACT, and he also said that the SWOG 1505 trial, that 25% did not undergo surgery. So I'll bring this in the next slide as well. But I want to share these points that though 15 to 30% do not tolerate adjuvant therapy, we have to see that 70 to 85% did tolerate them. And a major thought that goes along, that when we are starting NACT and the 36% who did not undergo surgery because of the toxicity of NACT. So, have we lost the golden window of resectability in such cases? So, I do agree with Dr. Yogesh saying that yes, in medically unfit patients for surgery while resectable, and in cases where the bilirubin is very high, we need to stent the patient and NACT, which might increase the morbidity. In certain situations, NACT might have a role, but what about the others clearly resectable disease? Here is the data starting from 2001. In early and complete surgical resection was said to be the only potential curative option for pancreatic cancer, and now adjuvant therapy is a great backup and has been proved to prolong survival with surgery first and adjuvant, which was a standard of care in resectable pancreatic cancer. This was given by Newton Lomis in 2001. So this is the basic flowchart that we follow. If the imaging shows a potentially resectable pancreatic adenocarcinoma head, we go for an upfront surgery. We try for a macroscopic curative. Try for an R0 resection, and then the eligible patients undergo adjuvant therapy. This would be the ideal pathway for all the patients. But does everybody fit in this pathway? Is the question. Let us also go through the adjuvant trials which have come over time. So this is a table from Devita itself, which is saying that so many trials have been conducted, and I will describe the main points followed by this, so that we can also see how the survival has increased over time. So this is the SPAC study, which was the first one, which compared chemotherapy and no chemotherapy, which said that there was a survival benefit of adjuvant chemotherapy, overall survival by 20 months. There were two other trials by RCTs by Burris et al. Who established gemcitabine, and the CONCO-1 trial, who also established the efficacy of gemcitabine in the adjuvant setting. They said that the patients undergoing curative resection were randomly assigned to surgery and adjuvant, and the gemcitabine group had a greater median disease-free survival, and the endpoint was significantly longer. And so did CONCO-1 say that gemcitabine is associated with a prolonged overall survival of 22 months. These are the corresponding papers to what we have just discussed. The SPAC3 trial compared the standard 5-fluorouracil, which was compared to gemcitabine. They said that there was no overall advantage, but the toxicity profile favored gemcitabine. The JASPAC1 trial brought in S1, which is a combination drug of Tegafur, that is a 5-fluorouracil, with gimseracil and otoracil potassium. They said that the overall survival with with S1 has increased with significant value, and it was well tolerated, and discontinuation compared to gemcitabine was lesser. So the overall survival was 46.5 months in the JASPAC trial. And now we come to the most commonly followed trials, category 1 according to the NCCN guidelines, which is the SPAC 4 trial, which says that GEM plus CAPE has increased the median overall survival to a whopping sorry, that's Prodige, has increased the overall survival. Also, that the Prodige 24, that the modified FOLFIRINOX has as adjuvant, which is most commonly used in the patients today who are eligible to have a good ECOG status to undergo the drug treatment, is 54.5%. And also that the treatment completion rate with modified FOLFIRINOX was 66% and 79% in gemcitabine. This is in contradiction to the point that we do have people who complete this treatment, that is surgery with adjuvant, up to 66 and 79% in the group. This is the NCCN guidelines, which just summarize the same thing. Now we have the concept of NACT, which was coming in. So let's study some meta-analysis. The first, some fewer ones were bought by Zhu and Andrew Lee and by Lee. So this one is by Andrew Lee. This was in 2012, where 20 studies were included and 366 patients with resectable. So they do have a portion of unresectable patients with unresectable disease which were included. But after evaluating and just noting down the disease for resectable lesions, I'll present the data. So the 1 and 2 year overall survival probabilities were 91% and 67% for initially resectable lesions. And the treatment toxicity was around 31%, which brings out us to the same numbers, that around 30 to 40% of our patients who are receiving NACT are unable to undergo surgery. Of the resectable patients directly after restaging, 91% underwent surgery and 82% of explored patients underwent surgery. This is the directly explored patients. So hence this meta-analysis by Andrew Lee said that there was marginal support to the benefit of neoadjuvant therapy for patients with resectable cancer. The next meta-analysis was by Zhu. This was in 2014, and they underwent they studied 17 studies and 3,000 patients were included. This study also had other aspects. One is comparing between CRT versus non-CRT, and the other comparison versus neoadjuvant CRT.
I think
Do we
we
have a
lost
problem?
connection with Dr. Gayatri. So, dear trainees, till the time you may type your questions, your comments in the chat box.
Yes, I'm around. There seems to be some connectivity issue, but if there is anything which Dr. Yogesh or I think Gayatri is trying to set it right.
Hello.
Hey, Dr. Gayatri.
Am I heard? The network went off.
Yes. Yes, you may start sharing your screen again.
Yes, one second. Am I heard? Excuse me.
Yes. Dr. Gayatri, you may start sharing your screen.
I'm just calling.
There's a question asked by Pratik about if at all we are starting neoadjuvant chemotherapy, what should be the margin at the pancreatic end? Am I heard? Am I audible?
Yes,
Shailesh, yes, go ahead.
Yeah, so actually, I haven't understood precisely the question by Dr. Pratik. Does he mean physical margins? Does he mean pre-treatment margins seen on scans versus post-treatment margin seen on scans? Does he mean the R0, R1 resection rates? And when he says pancreatic end, I think it's important at this stage when we are doing our DNB surgical onc that we are very clear which margins we are referring to. So maybe Pratik can rephrase that question more precisely, which is also a part of our learning together, so that I can answer you more precisely.
Shailesh, I think what he meant is like, in all other diseases like, breast or distal rectum, after giving neoadjuvant, we do a surgery. Does the margin status same change, or it's going to be the same margin status as in an upfront surgery case?
Yeah, so I think there is only one way to do a complete radical Whipple resection. So you do not go by you do not go by what you see on radiology. You go by the defined template of resection of a Whipple's procedure with a lymphadenectomy. So our judgment or intraoperative decision making in that sense is not very difficult based on whether you have given neoadjuvant treatment or not given neoadjuvant treatment. I think the strategies change a little bit when you are doing things like locally advanced pancreas cancer, when you want to do things like divestment, or when you want to add a vein resection. At that point in time, you may have to do certain technical maneuvers. But even after those technical maneuvers, the resection line is exactly the same as always.
Gayatri, is your network issues solved? Will you be able to share and complete it?
Within 1 minute.
Yes, sir. Yes, sir. I have to re-log in. There was some issue. I'm just sharing my screen again, sir.
Right.
Am I heard, sir?
Yes. You may drag the picture aside and start.
Yes, yes. So we were talking about the meta-analysis from Andrew Lee, which said that it had a marginal support to assume benefits of neoadjuvant therapies in 2012. Then we had gone to 2014's meta-analysis by Zhu, which concluded that out of total number of 189 patients which had received, which were compared between neoadjuvant and post-adjuvant CRT, the pooled hazard ratio was 0.93. Hence, the conclusion of this meta-analysis was that there was no actual benefit in OS and in progression-free survival with non-RCT, and neoadjuvant chemoradiation showed no significant effect over post-operative. Hence, as we know that the timing of chemotherapy is important, so whether to go ahead with a pre-op or a post-op chemotherapy, this meta-analysis said that the neoadjuvant arm did not have a big benefit over the treatment protocol. But there were some shortcomings of both these meta-analysis. They included other arms as well, and this study was not only focused to resectable pancreatic cancer, but they also included some borderline resectable diseases. And this is the next meta-analysis, which was given by Lee, which had a head-on-head comparison between neoadjuvant therapy versus upfront surgery in only the resectable pancreatic arm. Now, there were two protocols which were followed here. One was the intention to treat, and one was the poor protocol analysis. This is the main point which will give a good answer to today's debate. In this study, there were 14 studies which had an N of 2699 patients treated with neoadjuvant and 6992 patients with upfront surgery. I will So as you can see, these are the studies that were included in this meta-analysis. If you see the forest plot in the overall summary of the, we can see that NACT is being favored. But if we this diamond, and many of the studies are falling in line, saying that upfront surgery and neoadjuvant surgery both have equal benefit. But if we look at the next slide, this is the intention to treat and per protocol. Now, what is the difference in this? That is the intention to treat was defined as the inclusion of patients who received neoadjuvant but did not undergo surgical resection. So this is the patients who are progressed, and we have lost to give chance to cure here. And per protocol analysis was defined as the inclusion of the patients who underwent surgical resection after neoadjuvant therapy. So if we see these two, what are we getting? So in the patients who were intention to treat, we can see that the NAT and the surgical arm both are on the center line only, with only Fugi as 2017, sorry, with only ELPO in 2017 showing that upfront surgery has better outcome. If we go in per protocol analysis, that is all the patients who have received NACT undergo surgical resection, we see that this is favoring neoadjuvant therapy. But this is only those patients who underwent surgery. This does not account to the patients who have lost and progressed. Hence, we have lost the chance of cure in this category, in this numbers. There was another meta-analysis by Louis in 2016 showing the efficacy of neoadjuvant chemotherapy with resectable pancreatic adenocarcinoma. Their primary outcome was also overall survival, and the secondary outcome was an R0 rate, which was studied with RECIST criteria. There were 171 studies included, and finally, after studies, only 8 satisfied the inclusion criteria, and 833 participants were included in these studies. You can see these 8 studies and how neoadjuvant and resection has been compared head on head. We should also note that the N of these patients almost very less in the Cassidy and Gaucher papers and higher in the upcoming papers. That means yes, neoadjuvant is gaining some popularity recently. But if we go to see the one second. So yes, if you go to see the forest plot, considering neoadjuvant and the resection group, we can say that the plot of all these 8 studies almost crosses the center line, that is the neoadjuvant and the resection group, with only Godser study in 2008 showing a favorable number. But we also remember that that only 33 patients were studied here. So the N is very small in such cases. Wherever where RCTs are there, they only cross the midline as well. So the conclusion of this meta-analysis was that there was no improved OS rate and no in from neoadjuvant chemotherapy and chemoradiation in resectable pancreatic adenocarcinoma. DGS was give a decision analysis. This was in 2016. In this paper, they have defined which stage of pancreatic cancer would be better for neoadjuvant therapy, and they studied all the stages in which the following patients were studied and underwent surgery and neoadjuvant therapy. In the conclusion of this study was only in stage 3 the neoadjuvant therapy was had significant survival benefit compared to upfront surgery. However, there was no difference between the other 2 arms, that is in stage 1 and stage 2, where the number of patients we see is high. So this gives more power to our study, saying that the survival impact of neoadjuvant therapy is stage dependent, and we do not have any much advantage except for significant survival advantage in stage 3 and stage 4, that is in N2 bulky disease, and in stage 4 where the disease is going to adjacent organs as well. Now there is this new network analysis, the Bayesian network analysis, which also studies neoadjuvant therapy with resectable pancreatic cancer. This was a systematic review. This is a recent one, which is of 2019, as mentioned. Kindly look at the numbers. So the total N was 22,000, and as you can see, 0.8, 0.75 in the 2 arms, 0.7, 0.748 for neoadjuvant, 0.5178 for 2-year survival, and 0.5131. Then for 5-year survival, it is 0.2 and 0.06 in the surgery arm. So there are differences which do favor, but they also, in the network meta-analysis, this is a line from them, that the neoadjuvant therapy may offer benefit. However, they do not recommend the same even with such big numbers, which says that is it right to add more toxicity, 30% toxicity to these patients, and delay surgery, lose the golden window of resectability, and to add to another modality to surgery and adjuvant and increase the expenditure? If we study this plot, we see that if this is the center line, this is for upfront surgery here. So this we see that the survival between upfront surgery and the neoadjuvant treatment, we are getting, if this is the survival of upfront surgery and this is of neoadjuvant, we only see the purple dots and a yellow dot. Now, what does this say? This is the phase 1 and phase 2 study, or a and a prospective cohort study. Now, do these studies show, but do they have so much of weightage to change the standard treatment? Another study, what Dr. Yogesh also mentioned, was the PREOPANC study, but we have to notice that this study included the borderline cases as well. This has been published in 2020. Some details of the of this study were that resectable and borderline resectable patients were included. They received gemcitabine, some followed by radiotherapy, or an adjuvant radiotherapy, or to immediate surgery and adjuvant gemcitabine. The primary endpoint was overall survival and intention to treat analysis, with a median follow-up of 27 months. So in this in this study, we had 246 patients. As already mentioned, that the overall survival was 16 months with pre-operative and 14.3 months with immediate surgery, but the overall significance was not noted. Also, with respect to resection rates, was 61 and 72% with NACT and surgery, which was the p-value is 0.58, which is not here, not there. The R0 resection was 71% in patients who received pre-operative chemotherapy and 40% who received immediate surgery, which was significant. I do agree with this. Therefore, preoperative chemotherapy was associated with a significantly better survival and a locoregional failure-free rate, as mentioned before, with significantly lower pathological lymph nodes, perineural invasion, and venous invasion. Survival analysis, however, were not significant here. The proportion of patients who showed, survival analysis of patients who underwent tumor resection and started adjuvant therapy showed improved survival with NACT. With this is the p-value that is less than 0.5, which is significant, and the proportion of patients who suffered serious adverse effects because of neoadjuvant therapy was 52. This PREOPANC study still concluded that for resectable and borderline, this is the main factor that we in this debate we should take with a pinch of salt. That since borderline cases are included, therefore it is showing more overall survival benefit. If we analyze only the resectable part of it, can we please concentrate your median overall survival, median DFS, median locoregional and distant metastasis free survival? We see that these two are not significant, and the rate of secondary adverse events is 0.39. Hence, because of this arm study, we should take PREOPANC study in resectable pancreatic cancer with a pinch of salt. And hence, we still can't say that neoadjuvant study has a great advantage. As we can see in resectable arm, the overall the OS is similar, the DFS is similar. These are the other smaller studies which of neoadjuvant chemotherapy, which also give a resection rate of only ranging from 50% to 80%. So this can say that if we are giving a neoadjuvant chemo and or radiation, we are losing some patients in the study. So is between 50 to 80%. What has happened to the other patients? Because of chemotherapy sensitivity, the disease has progressed and has become inoperable, and have we lost the chance of cure? This is a table showing the RCTs of resectable and borderline resectable disease, which was studied, but again these n are too small. And but why I have included this in the slide is because the resection rate is almost similar, 60 to 75, with a non-significant p-value. This is what I wanted to bring into. Now let's get to the 2020 area, where we are asking us that resection, we know that resection is an essential component which gives cure, and now we have better surgical techniques with portal venous resection, so-called extended resections, and safer resections. So we can, by our surgical skill, practice, and referring to big centers with greater volume, can increase the chance of cure, decrease the morbidity of the surgery, and hence the patient can go into can have the full chance of cure. The recent advances, this was just released in August 2020, which says that we cannot classify patients as NACT or surgery, as it is an era of precision oncology and individualized surgery. There have to be some markers which say that such patients go into surgery and such type of patients go into NACT. So they have studied a protein, which is a calcium binding protein called S100A2, which has shown that if the value of this protein is high, it does it does show that it is a poor prognostic subtype. So this is associated with a poor survival after pancreatectomy, after Whipple. So does this value also show that if this comes into practice, such patients do have a chance of going under NACT? However, this study had also some limitations. The availability of S112 in other many centers and which samples are sufficient for studying it is under study yet. And therefore, there are two upcoming trials known as the Precision Panc in the UK and Precision Promise in the USA, which is studying these factors. We are also looking for head comments from the NORPACT-1, the NEOPANC, the NEPA Fox, and the NEONAX trials in order to get proper data as which will solve today's problems. So my conclusion for today is that we do not have level 1 data which still suggests the use of NACT in resectable cancer. Being a proponent of surgery, I believe that a chance to cure is more important. We should grab the chance, and hence we can avoid progression under neoadjuvant therapy arm, which would deprive the patients of further surgical cure. So we know that the morbidity is 40% of Whipples, and but we have been able to raise the survival up to 54.5 months under the Project 24. 70 to 85% do tolerate adjuvant therapy. We do have the golden window of resectability, and we are not losing on time. There was a study by He Stand, this I got from ASCOPub's ebook, which is saying that we should define the criteria of neoadjuvant in resectable pancreatic cancer, which is saying that large primary tumors more than 3 centimeters, increased CA19 levels of more than 1000, and N2 lymph nodes, involvement by imaging. These are criteria that can undergo NACT in resectable pancreatic cancer. For the others, which are good outcome diseases, we should undergo surgery. Therefore, in the good outcome patient who we are planning for surgery, we will not lose these. That is, we will give them the resectability benefit. Because OS benefit has not been still statistically significant, we will again give them a chance of cure by not wasting time going for NACT, and we do not take chances with progression to inoperable disease, and do not give the patient the morbidity of NACT and delay in surgery. So this is my conclusion, sir, that we operate on good resectable diseases earlier and do not give the disease its time to raise its ugly inoperable head, and NACT and NACT may be reserved for resectable pancreatic cancer, as I have previously mentioned, as high risk, as bulky tumors, CA99 of more than 1000, and that's it, sir. Thank you, sir.
Gayatri, thank you. Had it not been for the glitch you had, we can see that you are so much passion. Sometimes when passion comes to that, biases creep in. But overall, your slides and the way you put and the hard work you have put last 1 month is fantastic. That's what we want to bring through the student. Even though human beings creep in, when you develop passion, then everything looks white. And I would hand over to Shailesh now to give a balanced view of both and also share his thoughts, views.
Well, I think both these speakers have done an excellent job. So to be very honest about it, there is not more in terms of data that I can add to what has been comprehensively covered by both Yogesh as well as Gayatri. It's true though, at the end of it, if you really want to know, in the world of evidence-based medicine, that do we really have level 1 evidence to justify the need as a blind statement or as a blind guideline to go ahead with neoadjuvant treatment in resectable disease? The answer is no. This is not my opinion, but this is just the available data out there. What we are trying to do, which Yogesh did very well, is of course to extrapolate all the work that has been done by phase 2 studies, by retrospective studies, and some studies which are not just phase 2 and retrospective but not convincing enough, either due to data heterogeneity or when we discuss some of these studies, especially the S1 study by my friend Mikiaki Uno and Sohei Satoi, you realize that there are application issues, and there is one trial which is starting to show benefit in resectable disease. Now, the benefit that we see with borderline resectable disease in neoadjuvant, we want to quickly extrapolate it to resectable disease with neoadjuvant. I think we are not there yet. And the reasons for that were quite well elaborated by Gayatri herself. That if you have a lesion where the chances of your R0 resection is going to be high, if you're going to be having an operation in a center where the expertise is going to ensure that there's only about 25% morbidity and a very low mortality rate, I know the ballpark figure of people getting adjuvant treatment is not more than 50%. But in dedicated centers and units and teams, the number of people who get adjuvant treatment after surgical resection within 8 to 12 weeks, because timing of adjuvant is also important. And I specified 8 to 12 because there was one paper which was not cited, and that's by the Neoptolemus group, the SPAC group, which was also published in JAMA, which said that it's acknowledged that patients can get complications and that they do not get chemotherapy sometimes within the 59-day limit. But even if you give it within 12 weeks, that is 3 months of surgery, chemotherapy is supposed to be as effective. So that's one statement. The other statement is if your surgical outcomes are good, your figure should not be 50% getting adjuvant treatment. You should be having about 70 to 75 people. That means 3 out of 4 should be able to get their adjuvant treatment. That's the other part. The third part is that traditionally, resectable pancreas cancer without vein or artery resection is little more difficult surgery because of the pancreas, but the outcomes are actually, the perioperative outcomes are easier as compared to the softer glands that you see in a periampullary tumor. But the whole focus of this debate and discussion is exclusively pancreatic ductal adenocarcinoma. And there, to summarize in short, you have early pancreatic cancer, uncommon situation admittedly, small lesions which are less than 3 centimeters, away from major blood vessels. A standard template of a good Whipple resection is possible. No lymph nodes which are beyond the standard template, and a CA19-9 which is to be judged only in the absence of obstructive jaundice. If the CA19-9 is very high, I think those are the cases where, in an individual setting, based on retrospective evidence and data heterogeneity, we would be still justified in going ahead with neoadjuvant. But if these factors are not present, I think the level 1 evidence today is that you go ahead with surgery for resectable pancreas cancer. I know that borderline resectable disease is also resectable pancreas cancer. But for the purpose of this talk and discussion, we have divided pancreas cancer into 3 areas. One is clearly resectable, one is BRPC, and one is LAPC. I think we clearly have a lot of evidence supporting neoadjuvant treatment in BRPC as well as LAPC. We still are awaiting better outcomes and data to presently deny a patient a chance of surgery when there is resectable cancer. The challenge has come and the debate has come only because of one thing. If we had very effective chemotherapy, and I use this word even in the era of modified FOLFIRINOX, because now modified FOLFIRINOX, starting 10 years ago, as the best palliative treatment for stage 4 pancreas cancer with good performance status. It came in 2018 with Prodige, to the forefront as adjuvant treatment. So, have we made progress in the last 2 decades as regards chemotherapy for pancreas cancer? We have. But how good has been the progress? Are we looking at modified FOLFIRINOX as something like the way outcomes of lymphoma changed completely? Are we looking at the way chemoradiotherapy is effective in colorectal cancer? Are we looking at situations where the chemotherapy is something like imatinib, where the tumors just melt away or vanish or dramatically decrease in size? I think if we get there, such debates may not be there because then a larger number of patients would go for neoadjuvant. But because chemotherapy has not made the progress that was expected of it in a cancer which has multiple pathways which are active and aggressive cancer, and when you try to shut down some pathways, other pathways are getting even more aggressive. So it's not an easy cancer to treat even in the lab, nor in animals, and certainly not in human beings as well. So, despite our progress with pancreas organoids, trying to mimic the host environment in an individual patient, despite our progress in trying to understand pancreas cancer at a molecular level and with precision panc, etc., we still do not have very effective biomarkers or very effective treatment available. So, when we don't have very effective treatment available, we as surgeons should be very careful. And when I say surgeons, I say thinking surgeons. It's not just that we need to operate, but as thinking surgeons, we need to be objective that you need to do more surgery for pancreas cancer, which is underperformed all over the world. And perhaps the damage caused by not doing surgery is perhaps more than trying to give everyone neoadjuvant treatment, where the neoadjuvant treatment itself is still not as effective as one would like it. And that's the reason that you see these meta-analyses at the end. Many of them, of course, have a lot of data heterogeneity, but these meta-analyses at the end will tell you that when it comes to the overall survival, we haven't really made a big impact with chemotherapy, without chemotherapy, despite the improvement in chemotherapy. So I think it's important to glean through the data a little bit more carefully, and you require a multidisciplinary clinic for every pancreas cancer case to decide based on the ABC anatomy, the biochemistry or the biology, as well as the patient's condition and the circumstances in where you live, where you work, access to treatment, 1000 things that come into play when we individualize treatment. So we should use this webinar as an excellent resource. Thanks to the initiative of Dr. Somashekar. I'm sure the slides are an excellent resource because you both have done an excellent job. Use that as a backbone, but always keep your eyes and ears open and individualize treatment as a part of a multidisciplinary team, and then you are in a better position.
Superb, extremely well balanced view. Gayatri, both of you did extremely well. I really love the slides. The strength is actually reading in between the line, not creeping your biases. And both sides, left side, are very good. So convert it into PDF and put in our DNB webinar, WhatsApp, and both Telegram group for benefit of other students. Shailesh, fantastic, way you analyzed as always. At some time we would also need a faculty talk. There is one question which is there, sir, is staging laparoscopy mandatory before doing a Whipple's for head pancreas?
Not necessarily. I think if you have high risk features based on a high quality triphasic CT scan, patient's nutritional status is a source of concern. CA19-9 is a source of concern. The quality of the CT scan is good, but it's showing fuzzy planes and areas of concern. I think in those patients, we selectively do a staging lab. Otherwise, we would directly proceed to surgery, and we would be right 95 times on 100 in the era of modern imaging, as well as the ABC, which I mentioned to you. So I think we factor in all this and decide in an individual patient whether you should do a staging lab or not.
Shailesh, before I hand over to Navneet Singh, for the benefit of student, I just want you to say, currently as per the standard norm internationally, in a curative Whipple's pancreaticoduodenectomy for head pancreas, what is the acceptable morbidity, mortality, leak rate today? So which is a benchmark may not be one of the best institution, but below that is counted as an inferior. So I want students to know.
So I think the benchmark would be that the mortality should be less than 3%. The morbidity should be less than 30%. The clinically relevant POPF, CRPOPF, that means by the old classification, grade B and grade C, more than grade A, which is deemed as biochemical leak. I think if you exclusively look at pancreas cancer only and exclude peri-amp, then the CRPOPF rate will be less than 10%. But if you take all comers for Whipple resections, including peri-amps, your clinically relevant POPF rate should be anywhere between 10 to 15%. So despite that rate being 10 to 15%, your ability to salvage and approach well to end up the mortality of less than should be the minimum standard. I think every surgeon who values himself or herself as a pancreas surgeon should perhaps do 60 operations himself or herself to truly negotiate a learning curve, to get better R0 margins, to reduce the intraoperative blood loss, and to reduce the length of hospital stay, and ensure that more patients go for the gold standard of adjuvant treatment that is now defined in the last 3 years. So these would be the standards, and the last standard would be, of course, that if your patient has got neoadjuvant chemotherapy, then your patient should have an R0 rate which is close to 70%. R0. That means the chemotherapy is being effective. That means the surgeon is doing a good job, as well as the pathologists are well versed with pancreas pathology post chemo to be able to provide such high R0 rates. Because otherwise, the R1 rate is approaching 60% for classical pancreatic head cancer without neoadjuvant treatment. So I've brought in the gold standard of pathology as well and margin positivity, and the median number of lymph nodes minimum should be 15. There is no point in a surgeon doing a good job and the grossing is not done, and the final pathology report, which I routinely see from across the nation, that there is no synoptic standardized reporting of pathology. We have incomplete information despite Whipple operation being done. So how we do it and focusing on quality is very important, and you've raised a very important point about what should be the minimum standards for us to establish and raise the bar for Whipple resections.
Superb. Candidates mark that word. Take my word. This is extreme, beautiful word. It's beautifully done, and it's all evidence based with this vast knowledge and experience. Superb, Shailesh. Thank you very much.
Thank you.
All has to come to an end. I really wish we could engage you in a conversation full day. Thank you very much for taking time out of it and sharing your vast knowledge. And on behalf of all students, I can feel that I give my personal gratitude for sharing your time and knowledge with our student. Thank you very much, Navneet Singh ji.
Thank you, everyone. Thank you, everyone. And once again, well done, Gayatri and Yogesh.
Thank you, sir.
Thank you.
Thank you very much, Dr. Gayatri and Dr. Yogesh, for the presentation. Thank you very much, Dr. Shailesh and Professor Dr. Soma Shikhar for joining us. And thank you, trainees and faculty members for joining us.